infectious disease. We have two presenters, Dr. Rollins Ndejo from Makerere University in Uganda, and Dr. Sabea from University of KwaZulu-Natal in South Africa. Dr. Sabea will be joining us in about 20 minutes, so we'll get underway with Dr. Ndejo. I'd just like to introduce him. He is an assistant lecturer in the Department of Disease Control and Environmental Health at Makerere University School of Public Health in Uganda. He holds a PhD in Medical Sciences from the University of Antwerp in Belgium and Masters Science in Environmental Health from the University of West of England in the UK, and a bachelor's degree in environmental health science from Makerere University. Rollins has co-authored over 70 peer-reviewed articles in the areas of non-communicable diseases, community health, and environmental health, co-organized international conferences and meetings, and led a coordinated multi-year collaborative projects. In 2021, Rollins was a recipient of a Dr. Enver and Pearl Belgi Young African Leader Award for exceptional ability and commitment to improving the well-being of individuals in low-income settings. In 2020, he was nominated by the African Academy of Sciences as an outstanding early career scientist to attend the prestigious Nobel laureate meetings in Lindau, Germany. And now it's my pleasure to pass it over to him to present on the perspectives on sustainable health and multi-sectoral collaboration in Uganda in the COVID-19 period. Dr. Ndejo, over to you. You're muted. Or maybe we have lost him. Here we go. Are you there?
Yes, Aaron.
Okay.
Small, but I had the introduction. Thank you.
Okay, very well. Over to you, and I will. I'll just let you know when there's 5 minutes left.
Okay, great. So thank you for the kind introduction. My presentation is going to focus on perspectives on sustainable health and multi-sectoral collaboration in Uganda in the COVID-19 period. We can move to the next slide. So starting with the broader overview around the Sustainable Development Goals, which is the broader framework to which we are all moving. There's a lot of there's a call for us to end poverty, we want to protect the planet, but we also want to ensure peace and prosperity by the year 2030. What the Sustainable Development Goals do is to provide us this framework in which we can all work to achieve these goals, and also provide us the opportunity to rethink a lot of ways that we are using to actually make progress towards achieving health broadly, but also achieving the health-related goals. But then from 2020, we are aware that we had COVID-19 that came in and led to serious consequences on our economies at the national level, at the household level, a lot of impacts on social determinants of health, but also increased inequalities and vulnerabilities. The other thing that the COVID-19 did was to give us the opportunity to rethink how we are progressing towards achieving the Sustainable Development Goals, but also the need for us to work across sectors to avert complex challenges. And on the next slide that we are going to, I'll highlight some of the perspectives around, first of all, sustainable health. In this work that we did, we are trying to look at sustainable health as a multi-sectoral area for study, for research and education and practice towards improving health and well-being for all, but while staying within the planetary boundaries. This is a working definition that we're using at the Center of Excellence for Sustainable Health, a collaboration between Makerere University and the Karolinska Institute. So with this thinking that we need to think about health and well-being, not just for today, but also for tomorrow, we wanted to think about what stakeholders and the perspectives they have around sustainable health and how COVID-19 could have impacted this. And in this study, we looked at multi-sectoral collaboration more as deliberate collaboration among various stakeholder groups, whether it is government, working with civil society, working with the private sector, across the different sectors of health, environment, economy, and many others to achieve given outcomes. So with this framing of sustainable health and the framing around multi-sectoral collaboration, moving on to the next slide, we're interested in trying to find the perspectives of the different stakeholders in Uganda around sustainable health and how this could have been impacted by COVID-19, but also interested in establishing the gaps and needs around sustainable health and multi-sectoral collaboration in Uganda during the COVID-19 period. Next slide. So we conducted a qualitative study, really involving key informant interviews with 44 stakeholders. These stakeholders were multidisciplinary from various sectors, from academia, from the public sector, from the private sector, and civil society. But they also came in from health, environment, agriculture, engineering, and so many other different sectors, because we're interested in various views and perspectives that the stakeholders had. We did virtual interviews, especially because of the times of COVID-19. Physical interviews were not possible, and we synthesized these results that I'm going to share with you. And also to note that we did this study just after we had a serious wave of COVID-19, for that matter. And this study was done between February and April 2021. So we are really interested in the different perspectives that I'm sharing next. So reaching out to these several stakeholders, we're trying to understand what sustainable health means to them, especially with whatever was happening in the world then. And these are the few issues that came through. One was sustainable health really being about access to healthcare for all. And this case, stakeholders drove the idea that it's for us to think about sustainable health in any perspective, we need to think about everyone and ensuring that we leave no one behind, which is more of what the SDGs say. But also from the quote that I highlight on the right, one of the stakeholders was trying to share that we cannot think about sustainable health when systems do not deliver for those who are most vulnerable and those who are marginalized in society. And this, of course, they justified from the fact that during the COVID-19 period, there was a lot of vulnerability and that was exposed, and not everyone had equal access to healthcare. And without a platform where everyone can actually access healthcare, thinking about issues of accessibility, availability, and quality healthcare, then we wouldn't talk about sustainable health. And there are many other issues around equity in terms of access to healthcare, but also access to medical technologies that were brought up during COVID-19, that stakeholders felt that to dream about sustainable health, we need to think about a situation where we have access to healthcare for all. The other key issue was around sustainable health being people-centered. We need to involve individuals in terms of understanding and their own health. We need to involve communities. We need to involve households to take charge of their own health so that they're able to do much more. Because at the time, some of the examples they gave is when everything else failed, we went back to individuals and communities to actually do something within their own little ways, whether it is doing isolation at home, whether it is looking for remedies to deal with the situation. So we need a people-centered approach in terms of dealing with health. Stakeholders also have the view that we cannot talk about sustainable health when we do not have pandemic preparedness, because this ends in a very short while. When we have pandemics and we're not prepared, a lot is at stake. If the health systems are not resilient to deal with COVID-19 to deal with the other pandemics that we face, then we wouldn't be on a good path to sustainable health. And then the other issue here, lastly, is really around sustainability. Thinking about health, not just today, but also for tomorrow, which is a broad theme around can we keep within planetary boundaries as we think about health, and can we ensure that those who have the means and resources today can utilize them sustainably, so that those of the future generation can still also be able to do so without compromising that ability. And that quote from the someone from the private sector in the ICT department tried to emphasize that sustainable health is about being able to carry out an exercise recurrently. So for them, they're like, we need to not only look at what happens at the moment, but also look at the future. So we need to maintain health over a long period of time. So this broadly is around some of the perspectives stakeholders shared around what sustainable health meant to them. On the next slide, I'll share how COVID-19 had impacted their views and thoughts around sustainable health. Next. Yes, so having this pandemic and having a lot of reflections, stakeholders shared how COVID-19 had impacted some of their thoughts around sustainable health. And one of these was to really think about the need for resilient, responsive, and sustainable health systems. So stakeholders tried to emphasize that it was more urgent for us to have resilient and health systems that are responsive and sustainable in a way, because this was the basis for everything else. Because during the time, everything was halted because we didn't have systems that were resilient. But also a broader reflection that across the world, even when we thought that some countries had health systems that were responsive and sustainable or resilient, this was actually not the case. So they felt that we need to rethink how we do health systems, but also how we think about resilience in this case. Stakeholders also mentioned that they felt that government needed to prioritize health more, because health seemed to be the basis for a lot of what we saw. But also at the time we conducted this study in the context of Uganda, we had a lot of private sector involvement to support, especially COVID-19 treatment. We had very few ICU beds, and so the private sector came in to support. But there was a lot of exorbitant costs from the private sector, and from the stakeholders, the whole idea was government does not need to leave the mandate of health to anyone else, but it should prioritize and invest more so that everyone else has access to this healthcare before the private sector can come in to support a few other individuals. Issues of equity in health and its determinants were also very important, especially that when we talk about the vulnerable groups, there's a lot of exposure to some of these groups within the different contexts. So stakeholders felt that we cannot talk about sustainable health anymore without thinking about those who are left behind. We had interventions that are targeting the urban poor, for example, even to provide maybe meals, provide some food, and provide some small income, which is all around health and its determinants, and also how some urban environments cultivated a lot of vulnerability for members. Issues around technology also came out clearly, because when everything came to a halt, it was technology that was able to carry us a bit through. So stakeholders felt that for the future, we need to think about how do we embrace health more and tap into this for most of our in terms of improving health. But also community empowerment and participation. I highlighted a bit about this. The need to ensure that we have an empowered community that is well connected with what is happening, so that they can lead some of these responses in their own way. And part of what I bold here is this whole realization that health is interconnected with all the other sectors. This was a very key perspective that came through in terms of this work. People feeling that health is interconnected with all the sectors, and if we think about addressing any health issue or achieving anything health-wise, we need to think about it in a multi-sectoral way. And that transitions us to the next slide that talks about multi-sectoral collaboration. So these were some thoughts that stakeholders had around COVID-19 and how it had impacted their views around sustainable health and what they thought needed to be done better and differently. Next.
4 minutes.
Great, thank you. So in terms of multi-sectoral collaboration, of course, we have had a lot of thoughts around multi-sectoral collaboration. So we reached out to the stakeholders to understand how COVID-19 had impacted their perspectives on multi-sectoral collaboration. Three key issues came across that I highlight. One is that they felt that the problems that were due to the pandemic actually cut across all sectors. So they're like multi-sectoral collaboration becomes even more important when dealing with pandemics, but also the problems that were brought about by the pandemic. And one of the quotes here from someone in civil society said that we have a pandemic that has affected all aspects of life, whether it is health, whether it's social life and the economy. So it was very important for all sectors to collaborate as in terms of dealing and mitigating with the challenges that the pandemic had occasioned. Related to the theme of still working across sectors, another stakeholder noted that we need to plan jointly because all these consequences that were due to the pandemic were cutting across all sectors, and by having everyone on board, then we can have you can be able to come up with long-lasting solutions. I know the stakeholder mentioned that now that we are beginning to say, how do we look beyond the individual sectors? If the program is about health, education, and agriculture, if the program is about health, education, and agriculture are important because a sick, hungry child cannot learn. So stakeholders had these perspectives of appreciating more of the role of multi-sectoral collaboration. And the last point here was around efficient utilization of resources. One of the stakeholders noting that by working across sectors, by integrating more, and by acknowledging that many of the problems actually multi-sectoral in a way, that could support joint planning and efficient utilization of resources, as highlighted in that quote. So I'll go to the next slide and talk about some of the gaps and the needs stakeholders expressed in terms of moving towards sustainable health. So several gaps that exist, but also some of the needs. Stakeholders highlighted that we need to rethink targets, indicators, especially for monitoring and evaluation. If we want to achieve sustainable health, what are those indicators? What are those targets that we need to track? And how can we increase awareness of these goals and targets so that everyone is on board and we can see how we are all moving? Issues around multi-sectoral work. We want to achieve multi-sectoral work, but how about the coordination structures? How can we improve these? How can we integrate data sources a bit more and share data among sectors? But also, how can we involve beneficiaries or service users more than we have been doing? So these are some of the issues that stakeholders highlighted. There are issues around translation of research into action, whether it is building research infrastructure that is still limited in a way, but also how we can guide priority setting, do a bit more evidence-based policy making. And I need to note that at the Center of Excellence for Sustainable Health, we are making a lot of efforts to develop some tools to support multi-sectoral work and support translation of research into action. But this is in response to some of the gaps that we have seen elsewhere. And the last need, of course, remains funding. There's a lot around funding. We need to increase government funding for research and programs. We need to ensure that there's equity in this funding, but also having a bit of predictability. Sometimes donor funding is not sustainable, it's unpredictable, and this makes it quite hard to target. Next slide.
1 minute.
So to conclude, that will be sufficient. Thank you. So to conclude, this was really to share some of the important perspectives and reflections around sustainable health and multi-sectoral collaboration as shared by our stakeholders, which we need to positively harness, but also need to, of course, build on some of this momentum, whether it is from multi-sectoral collaboration, momentum for sustainable health and for working across sectors, to bridge some of the gaps that exist that I've highlighted, whether it's in funding, in translating research to action, in targets and indicators, to ensure that we move towards sustainable health. And yeah, that's really what we're sharing. And all these perspectives are important for us to deal with COVID-19 now, but also to think about the post-recovery phase as we move. Next slide. Yes, to acknowledge our stakeholders who shared their perspectives with us that have been able to relate to you. Those who supported the research officers, Brenda, Leslie, Sherifa here. This work was funded by the government of Uganda through the Makerere Research and Innovation Fund. That I want to acknowledge the Center of Excellence for Sustainable Health team, but also several colleagues at the center with whom we worked on this piece of work. Over to you, Aaron. Thank you.
Thank you very much, Dr. Ndejo. One question from Dr. Nasulu for you. On access to health for all during the pandemic, please highlight on what happened in Uganda regarding what other authors call missing millions, the homeless migrants, illegal migrants, people in humanitarian crisis, etc. These groups have shown to be missed out across the globe during COVID pandemic regarding access to health and other services. Any thoughts on that regarding Uganda?
Well, of course, the whole point around access to healthcare came about that some of these groups are usually left behind, and it's not any much different here in Uganda, whether they are refugees, whether they are the urban poor, and everyone else. And at the beginning of the pandemic, when we looked at some data around access to some of the essential health services to keep growing, we found that some of these, of course, it was very hard to tease out who was being left behind, but broadly, we know that when access to healthcare starts to reduce, those who are most marginalized and those who are vulnerable are usually left behind in that sense. But in the broader health system, some of the papers that I've seen around some of these groups, whether they are refugees, whether they are people who are living with disabilities, the story is the same. So the point of stakeholders from this perspective was more around, we need to build health systems that will not consistently leave some of these people behind in a way. And that drove a bit of the thinking around this theme for that matter.
Okay, thank you. Is Dr. Sibea online? It's her turn now. Are there any other? I don't see her online, however. Are there any other questions for Dr. Ndejo? Wondering if we have.
Yes, hi, I am online. I don't know if you can hear me now.
I can hear you now. Okay, so thank you very much, Dr. Ndejo. Very much appreciate that. We're going to move on now to Dr. Sibea, and I will give a brief introduction for her. So,
give me a second. As soon as I turned on my mic, I lost the share screen button.
is there any chance that the organizers can post the presentation?
I can definitely share your screen for you, and you can just indicate with the slides. We're not too sure why the share screen option is being so difficult today, but I'll definitely share the slides for you now.
Register it as a number. So
I think one of my collaborators, Emily, might have a copy of the PowerPoint as well.
I have the PowerPoint that you sent through to our tech team.
They have your presentation that they sent through to the tech team, so they can use that. Is it okay? Here we go.
So that would be the wrong one, unfortunately.
Okay.
Unless it's the one. Yeah, I'm so sorry about that. Emily, are you online? Are you able to share your screen, or is it a general problem? My apologies. Is there one from today? I sent one again today to the tech team. Alternatively, I will leave and just rejoin. It shouldn't take me more than a minute.
And maybe you could also email them the presentation.
I've emailed it to them today again.
We're just having a look in our email now, and I will let you know.
Thank you very much.
We haven't seemed to have received your one for today. Can I ask you to either resend it, or do you want to try leave and then come back in and see if you can share your own screen again?
It would be to Durkee, is that correct? Hello, sorry, I just wanted to double check.
Sorry, we're just double checking his email.
Durkee van nummer 42.
All right, he's going to have a look now. We were just online when you sent the new version, but we're going to copy it over now, so it might just take us a few seconds. If you could just give us that moment, and then I can share screen again.
My apologies, colleagues. It is a relatively short talk, and I'll try and summarize it and get to the meat of it as quickly as I can once we start, so that we don't run over at the end of the session.
Okay, so right now we have 15 minutes. Maybe I'll just do the quick introduction for you. So Dr. Sibiya is an ear, nose, and throat consultant with serving with the public healthcare system in KwaZulu-Natal, South Africa. She has a special interest in global health and global surgery, and is passionate about developing and implementing strategies for improving clinical service delivery and access to specialized care. She will be presenting on COVID-19 and complicated sinusitis case series and review of the literature. And as soon as your presentation is up, Dr. Sibiya, you can begin, please. And I will let you know when there might not be much time for Q&A, but I'll give you a heads up when you have, shall we say, when it's, so this session's over at 2:35. I will let you know when it's 2:32. Okay, there we go.
Great, is this mine coming up now?
It should be yours if you can just give it a few seconds to load, and then it should share.
Excellent, thank you. All right, is this
all right?
Please.
Is this correct?
If you could just show me the next slide, please. Okay, yeah, that looks good. Thank you. Great. Thank you so much, everybody, and again, thank you for your patience as we got this sorted out. So I am Andile Sibiya. I'm presenting from the city of Durban here in KwaZulu-Natal. You can show me the next slide, please. Complicated sinusitis is a very severe condition, which is a progression of a post-viral bacterial sinus infection, wherein the sepsis spreads into other parts of the body, in particular the head and neck, either into the eyes, the frontal sinuses and forehead, or intracranially. This condition has a very high mortality, especially when there is intracranial complications. And the listed complications in terms of how we define the disease include having a preseptal cellulitis, orbital cellulitis or abscess, cavernous sinus thrombosis, intracranial abscesses, and then either an epidural or a subdural empyema. Next slide, please. Multidisciplinary care is the standard in managing these patients. The primary disease and disease source control is in the hands of the ENT surgeon. When there's intracranial complications, this requires a neurosurgeon. Ophthalmology is often involved if there's an intraorbital collection or intracranial collection. And then, of course, we involve other disciplines as required. So some of these patients may have a meningitis. When they've got really severe sepsis, they may even develop things such as organ failure and require ICU care and the care of specialists in that domain. Next slide, please. Well, in the context of South Africa, we actually still have amongst the highest levels of complicated sinusitis in the world. These numbers vary depending on which study you look at, and the mortality rate has been documented as being as high as 20%. This is obviously if there is a severe intracranial complication. Most of these patients are under the age of 20, and the disease seems to have a predilection for males over females. So in red there is the province which we're coming from. And surgery is the mainstay of care, where you have to get rid of the sepsis. And as you can see, these patients respond quite well to that in terms of having burr holes and disease and sinus drainage. One of the key things is that these patients often have quite a recalcitrant course, requiring multiple surgeries to adequately clear the sepsis within these contained spaces. Now, within the last 2 years, as we're speaking about COVID, we know that COVID brought us a lot. Next slide, please, or click. COVID brought us a lot of complexities in how we manage our patients. Some of you would have come across the COVID surge study, which was published just over a year ago, which raised a lot of concern around the morbidity and mortality that was associated when doing surgery in patients who had co-infection with COVID. Click, please. And one of the key recommendations was to try and find ways in which we could either reduce surgical interventions or avoid them completely. Now, this isn't always possible, particularly in conditions such as this. Next slide, please. So we set out to go and establish a few things with our study. The first was to try and establish what effect COVID-19 co-infection had on complicated sinusitis outcomes, in order to be better informed about the proper medical care and whether or not we could de-escalate some of our surgical interventions in future. We also wanted to see what the effects of COVID-19 co-infection was on complicated sinusitis disease progression and possibly presentation, and also understand the demographics and complications that would affect these patient outcomes. Next slide, please. So, in our literature review, we obviously found only 10 reports of co-infection with complicated sinusitis and COVID-19. And none of these were a full case series of 10, but rather sporadic reports. In our study, we identified 14 patients. We did a retrospective chart review looking at all the complicated sinusitis patients that had been seen from about March of 2020, when the pandemic was declared, to May of this year. This study was covered under our ethics approval for both neurosurgery and ENT databases. We then conducted a randomized match of COVID positive and COVID negative cases, and then did some descriptive statistical analysis on these cases. Next, please. In total, we had 125 cases of complicated sinusitis during this period. Of these, 14 had co-infection with COVID and 11 were COVID negative. We did our 2-to-1 matching for age, comorbidities, and complications. and ultimately ended up with a series of 14 COVID positive patients and 28 COVID negative. Within our study, we found that the mean ages between the two groups were similar. There was no statistical significance in age, nor was there a significant difference in gender, race, and in fact, all those demographics matched what we would expect outside of this pandemic for the disease itself. Next slide, please. In terms of our complications, most of our patients did have a subdural empyema. This is in both COVID positive and COVID negative cases. Some of them did have multiple complications. So a patient may, for example, present with both a subdural empyema and an orbital cellulitis, but this was rare. There was no particular difference between the presentations and the frequency of these complications in either the COVID positive or COVID negative group. Next, please. In terms of our cultures, most of the patients had what we expect, which is a streptococcal infection. There were a few isolated cases of atypical cultures such as E. coli, but typically what we saw was pretty much what we had expected. There was no difference between the two groups, between the COVID positive and COVID negative group. Next slide. We looked at our average length of stay. Although there was a very slight increase in the length of stay for patients who did have COVID in ICU, statistically speaking, for both non-ICU stays and ICU stays, there was no real statistically significant difference for these patients. Next, please. So ultimately what we found was there was no significant difference in mortality between the two groups. There was no statistically significant difference in average length of stay in ICU or in hospital. Also of note is that we found no real difference in the number of surgical interventions that these patients had to have, remembering that, of course, this disease does require often multiple interventions, with frequently going back to the patient to do a relook or wash out again when there's a recollection. And also there was no significant difference in the organisms that were cultured. Next slide. So in conclusion, this is the largest cohort of complicated sinusitis patients that has been reported who are co-infected with COVID-19. The sample size remains small. However, from what we've been able to describe, we feel that the results are still quite significant. Ultimately, there are no major changes that are required in the care of patients who have COVID-19 as a co-infection. The later, I must add a disclaimer here, the more recent Global Surgery Collaborative reports on COVID-19 and co-infection in surgery do seem to be leaning towards this as well. And this becomes particularly important for us. Next slide. Next one, please. The study took a lot of hard work, and we're very grateful that we have a great team of collaborators who were able to work with us. The study was led by ENT and neurosurgery at the University of KwaZulu-Natal, with the support of our virology department, as well as our great student team and consultant team from the University of South Florida in the United States. Thank you very much. Are there any questions? I hope I've managed to catch up on time a bit.
You have managed to catch up on time. We have 3 minutes left. Congratulations. Very much appreciated. Very fluid presentation. So that was great. Are there any questions? Any questions for Dr. Sibiya? Hoping that there are a couple. Yeah. So the overall conclusion is just, if you will, carry on.
Yes. Now, this was obviously an interesting time, and it's always interesting when we reflect back on our COVID. You know, those of us who were in the midst of it right at the beginning of the pandemic, remember the panic and fear that ensued. And particularly for us as head and neck surgeons working in the sinonasal tract, where the risk of healthcare worker infection is so high, making decisions around whether or not to intervene surgically was actually quite critical. Because obviously, I think you'll know that some of the first few surgeons who passed away were neurosurgeons and ENT surgeons. And so we had this conundrum where we had this condition that needed to be managed surgically that put the team at risk, obviously, if the patient had co-infection with COVID-19. In addition to that, from a patient perspective, we had a lot of the early literature coming out saying, wait a second, don't do too much for these patients, because if you do something for a patient with COVID-19 co-infection, you're actually going to make them worse. So is there a way that you can reduce the number of interventions or downgrade the type of intervention you do surgically, sort of get in and out as quickly as possible? And we internally as a team had quite a few discussions around how we would proceed if and when these cases came out, knowing that we had a significantly higher burden of disease, it appeared, than many other parts of the world. So they would be seeing these cases once or twice during this pandemic. And we, as you can see, had a total of 14.
Yeah.
So certainly it became quite important for us to be thinking actively as we moved forward. Ultimately, as we were doing it, we decided that we were going to proceed as normal. We were really fortunate, obviously, to be able to get PPE for the team and that sort of thing, and reduce the risk to the team. And we did make some changes to sort of the choice of instruments that we used, reducing aerosolization, having additional suction in the operative field to reduce aerosol, during the procedure. But ultimately, it was important for us to look back and say, well, now what? In the last 20 years, we've had two other major pandemics. We've had the MERS and we've had SARS. And I think everyone agrees that we don't think COVID-19 is going to be the last time we see something like this. And so looking back at what happened with this becomes a lesson for what we can expect moving forward as well.
Okay. We do have a follow-up question. Will you be doing a study with long COVID patients and without?
So in this particular cohort, because the disease is acute, right, and the key here is the management of the acute condition, long COVID tends to sit on the outside of the kind of the complicated sinusitis. Certainly as ENT surgeons, we see the impact of long COVID. So we've had the patients with the disruption of the sense of smell, with the disruption of taste. We've also seen those who've had the transient hearing loss as a result of SARS-CoV-2 infection. We don't have any plans at the moment to be exploring those in terms of long COVID, but I know that our colleagues who are the physicians and infectious disease specialists are looking at that.
Okay. And the person asking the question thanks you for that. Not a medic. So it's so thank you very much. Thank you to both of our presenters. Very interesting presentations. Very much appreciate it. We've gone slightly over. I don't think that matters. However, it's tea break, networking and poster session. So unless if there are any other questions, we'll end it there. Please complete the session evaluation, please. And also, please look for the notice at the end of the day today and the end of the day tomorrow for an evaluation of the days, because it's really important. It's the first time this CUGH and a university in Africa have combined to do a global health conference focusing on Africa. And it's a hybrid model which combines both the virtual and the in-person. And so we're hoping that we get some good feedback about what's worked well and what hasn't worked so well. So please complete it. I see that it's posted right now. So thank you again, Dr. Ndejo, and Dr. Sabia. Apologies for the mispronunciation. I worked with my Zambian friend on it, but my B's were always too harsh, and so next time we meet, I'll get it down pat. Thank you.
Thank you, everybody, and thank you to the technical team for picking up the slack there.
Have a good
Indeed,
afternoon.
thank you, everyone. Bye.